Morning, everyone. It gives me great pleasure to see a packed house on Saturday morning. So, the entire session based on in-hospital management, I mean, the way the speakers decided, Dr. Eamon has given us a great insight into the magnitude of the problem, what they're doing in UK in terms of the audit, what it shows up, what they've been doing there to avoid or reduce the complications or hyperglycemia or decay. We are not that rich in data here. We don't have those many audits and data telling us the numbers as to what is happening in India. All of us have some isolated idea of what's going wrong in the hospitals. But this gives us food for thought. That probably the group that came across or was invited by IDEC to write the guidelines should probably work on looking at these data, collecting data as to what the Indian statistics are. So I will stick to talking about what are the guidelines for management. These are the RSSDI 2016 guidelines, which have been based on various guidelines from across and some Indian evidence. So diabetes around the world, and India, we know these statistics from IDEC and the magnitude of the problem. So India is right up there, projected to reach up to almost 120 million odd by 2040. So India was the largest contributor to regional mortality, with 1 million deaths attributed to diabetes. So why are we talking about this? Acute illness results in a number of physiological changes, like increase in stress hormones or therapeutic choices like steroids, which can exacerbate hyperglycemia in the hospital. This in turn will lead to various other pathological changes, which eventually affect the stay in the hospital, the morbidity, and sometimes leading to increased mortality. A systematic approach to the in-hospital management has consistently demonstrated better patient outcomes and reduced burden on the healthcare system, just as shown by Dr. Eamon in his previous presentation. So if you were to define it, what is purely hyperglycemia in the hospital defined as, is any blood glucose that's more than 140 milligram per cent will be defined as in-hospital hyperglycemia. The burden of this, as I said, we have the data, but statistics from across the world, we don't have much Indian data on this yet. In a review of medical records of roughly 2,000 patients admitted in a hospital in the US, 38% of patients had been documented to have hyperglycemia, out of which 26% had a known history of diabetes and 12% had no history of previous diabetes. It's this 12% which actually is at a bigger risk for landing up with greater morbidity and complications. So stress hyperglycemia, new onset hyperglycemia always indicates that something is going on wrong much more even than in a known diabetic. Observational studies have reported prevalence of hyperglycemia ranging from 38% to 38% in community hospitals, 70 to 80% patients with acute coronary syndromes and CABG surgery patients. Where I spend a lot of time in Mumbai at the Asian Heart Institute, we have similar figures. Almost 60% of the patients admitted there for cardiac care have previous history of diabetes. So if you have to classify this hyperglycemia in the hospital, how do you do that? One is previously diagnosed. So existing known hyperglycemia prior to hospitalization. One of the reasons as to why we need to classify this, besides other aspects, is labeling even from the insurance purpose as to the patient whether they had previous diabetes, is it new onset diabetes, etc. Previously undiagnosed diabetes means at admission you've come to know fasting sugars or PP sugars or a random sugar is high and it classifies that as diabetes. You do an HbA1c, so which is what the group strongly recommends for patients admitted to the hospital, whether known diabetics or newly detected hyperglycemia. If there is no HbA1c available in the last couple of months, please do an HbA1c at admission for all these patients. It guides you in a lot of ways. It of course guides you in knowing whether this patient had previous diabetes. It also guides you in deciding the treatment options at the time of discharge. Stress hyperglycemia, of course, will be those who have sugars which are on the higher side now, but the A1C is less than 5.7%. Yes, of course, there are some limitations to HbA1c in certain scenarios. Withstanding that, HbA1c does serve as a great tool in identifying the new and old patients. So, clinical recommendations for management of in-hospital hyperglycemia, it can be broadly classified as critically ill, non-critically ill, special circumstances. The time today would not allow me to cover all these aspects, but we'll try and throw light on some of these. So, when you talk about the critically ill patients, what is the target in the ICU settings? It's 140 to 180. In the non-ICU setting, when you look at, you're looking at a fasting of 80 to 120, a pre-meals of less than 140, and a post-meal of less than 180. These figures have been derived from various recommendations, and of course, as Dr. Sanjay already introduced, Dr. Ambaris is here, whose work actually guides a lot of other societies and organizations to have their recommendations, and the Indian recommendations too are based on a lot of work done by him and others across the globe. Managing diabetes in the critically ill patients. For the majority of critically ill patients in the ICU setting, insulin infusion should be used. That's something that we all agree on. Blood glucose more than 180 should trigger insulin initiation. Once intravenous insulin is started, the glucose should be maintained between 140 and 180. There was a time that there was a drive that we should try and push it less than 140. People were looking at 100, and various studies done over the years then has finally put some consensus towards this, that we are not looking at being very aggressive. 140 to 180 is a decent target. Only in a small subset of patients you might want to target to 110 and 140. These small subset are going to be like patients with post-cardiac, post-CABG, post-cardiac surgery. Otherwise, predominantly your target needs to be 140 to 180. Managing diabetes, preparation of insulin infusion. I'm going to skip this. That's a standard instruction for how you prepare insulin infusion. The instruction given to nurses in the wards. Now, adjusting the insulin infusion rates. It's a busy slide. One need not worry about this, because at the end of it, I'm telling you where the references are. All this is published data, and all of you who are interested in looking at that can get to that. For the ease of every one of us who's working in the hospital as to how to use this, these calculations have been put into an app called Inspro. So the group owes a lot to Dr. Panikar, under whose guidance we all worked. Of course, RSSDI is the one which told us to do this. An app has been made which any of you can download both on Android and iOS, which gives you this exact calculation. So you need not worry about how to go about it. What this basically tells you is the algorithm. If the patient is on target, whether you're going to increase the sugar or not, it's based on what the previous sugars were, how fast the sugars are moving, whether they are coming down, whether they are going up. If there is a reduction in the sugar, again it's based on whether the sugars decreased by, the rate of decrease was less than 25%, whether it was between 10 to 30 or was it much more than 30 milligram. On the basis of these calculations, you will decide whether I want to decrease the dose by 1 unit, I want to decrease by 2, at a point do I want to suspend the infusion. So one is, you can understand this algorithm, it will take a while. Alternately, this app allows you to just enter the patient's data for once and then keep entering the sugar value, and the software or the app is going to tell you what should be the next insulin dose for the next hour or two. This can be used by the nursing staff, this can be used by junior doctors or residents in the ward. What about the non-critically ill patients? The targets for majority of non-critically ill patients, as I showed earlier, continues to be similar, less than 140, and post-mean sugars to be less than 180. In general, of course, in the non-critically ill in the hospital, insulin is going to be the preferred treatment mode in the hospital. Having said that, in the Indian scenario, the perspective, if patients are admitted just for daycare procedures, which do not warrant the need for them to be nearby now for more than 6 hours, in these patients, you can consider continuing or using their orals, or probably just skipping the dose of the oral on the day of the procedure. And by late afternoon, when the patient starts eating again, you can restart the oral medications. Beyond that, if patients are going to be admitted overnight or require hospital stay for a longer period, it's best to stop the orals and move towards the insulin therapy in the hospital. What about insulin initiation in the hospital? Common approaches are the sliding scale insulin. A lot of people are still using sliding scale. The group strongly recommends against the use of sliding scale insulin. Sliding scale insulin is based on administration of a pre-established amount of short-acting insulin in response to hyperglycemia. So in a sliding scale, you always try to catch up. You gave 8 units of insulin in the morning based on the sugar being 160, because that's what the sliding scale said. At pre-lunch, the sugar is 240, and the sliding scale says that you give 14 units, you do that. By dinner time, the sugar is down to 110, and then based on your sliding scale, you're going to be giving 4 units. Now for lunch, if you landed up giving 12 units to cover up lunch, even though the pre-dinner sugar is 110, logic will tell you that the patient will require at least 8 or 10 units to cover up dinner. But the sliding scale will tell you, because it's 110, you need to use only 4 units. Which is why sliding scale is kind of redundant. You keep on doing a catching up thing in the sliding scale, and it's not recommended. What are the preferred insulin regimens? Depends on your comfort level. You could use the basal bolus therapy, which a lot of people prefer in the hospital, as it gives you maximum flexibility and probably better control. You could stick to using NPH and regular insulin, or you could be using the analogs. So a lot of times in the hospital, in the ward scenarios, we tend to use the short-acting analogs, and then we use the long-acting basal insulin analogs. Sometimes, if you're comfortable in the Indian setting again, people tend to use premix analogs. If patient has been on it in the past and you don't want to change as patient sugars have been stable, I guess you're okay to use that. A lot of people will argue against the premix insulins in the hospital scenario, as it doesn't give the flexibility to the doctor that you require. Having said that, as I said, if somebody is on it before and you prefer to continue it, it's probably alright. Use of incretin-based therapy with basal insulin with supplemental rapid-acting insulin is another concept. There have been papers in the recent past, use of incretins like sitagliptin. So they have had studies where using oral sitagliptin with basal insulin and then using supplemental short-acting analog only where required has probably done as well as using the basal bolus therapy. What about the estimation of the total daily dose of insulin? So how do we go about it in the hospital? If somebody is admitted for the first time, I think the dilemma is typically when patient has been on oral admitted to the hospital, how do you calculate the total daily dose of insulin? These are some simpler calculations based on the weight. So if you see the scenario here, whether it's ideal, obese or a lean patient, you decide on the requirement. Let's assume we have an ideal body weight patient, so you're going to be starting with 0.4 unit per kilogram body weight. On that basis, you will calculate the total daily dose. Once you get the figure of the total daily dose, you use probably to begin with 80% of that. When you're starting off with insulin, you use basal insulin as 50%. I did mention in my other talk yesterday that personally I prefer to use 40% as basal and use 60% as boluses because of the high carb content in the Indian food. If somebody is already on insulin, or if somebody was admitted to the ICU and you gave intravenous insulin there and the patient was there for 2 days, 3 days, 4 days, how do we calculate during the transition to the ward? Again, one of the ways of going about it is, what you look at is the 6 hours of stable sugar control over the last 6 hours. That value, so suppose the patient was at 1.5 unit per hour and you were looking at 6 hours, you're getting 9 units. You multiply that by 4, you're getting 36 units for the day. Again, of that you use 80%, you're transiting from IV to subcute, 80% to begin with just to be on the safe side, divided on the similar means of 50% basal or 60% basal, 40% basal, sorry, and the remaining in bolus, and then titrate in the days to come. What about the role of oral anti-diabetic drugs? The use of oral and other non-insulin therapies presents some unique challenges. So we know some of the patients are on GLP-1 receptor analogs, and a lot of them are on other orals. Do we continue to use them? Do we stop them? So there are certain clear contraindications for the use of these. So when you have patients with sepsis, there's going to be nil by mouth, where you have the need to use an IV contrast diet, pancreatic disorders, renal failure, etc. Clearly you're going to be stopping the oral medications there. The ideal candidates for continuation of previously used oral drugs are those who are absolutely clinically stable, who are eating their regular meals, are not going to be missing out on meals, and who have no contraindications like the ones listed above to any of these agents. Management during the procedures, well, the pre-procedure sugar control, so when you're talking about any of the procedures or even minor surgeries for that matter, dental procedures, cataracts, etc. What is the recommendation? You're looking at ideal fasting of 80 to 120, acceptable is up to 140, but if it continues to be more than 140, you might want to intensify the therapy. Similarly, the values for postprandial, and then HbA1c ideally less than 7, acceptable up to 8 for doing a procedure, not for overall control. But if the A1c is higher than 9, then you're probably looking at intensifying the therapy before the procedure. What about for morning procedures? On the day prior to procedure, patients should be advised to take full dose of anti-diabetic medication, including insulin and OEDs at dinner. These are largely for minor surgeries. The patient remains NPM till the procedure is complete in the morning. Patients should take their usual dose of insulin and or oral drugs when they have their breakfast by mid-morning. So this is typically for, as I said, dental procedures, some diagnostics, scopies, cataracts, where most of this ideally should be done in the mornings. We always recommend, and the group also feels strongly about recommending in hospitals that wherever there is a list of procedures and surgeries, the diabetic patient should be kept higher up in the morning. Having said that, there are some hospitals which will have 8 cases and out of these 6 are diabetic, so you obviously can't have 6 diabetic patients as the first ones. The rest will go down to late afternoon. For patients who are not on insulin, those are on oral drugs or GLP-1s, what do you do? All OADs and GLP-1 receptor agonists can be continued as usual on the day prior to the procedure, but should be omitted on the morning of the procedure. They can be again restarted once the patients resume their diet. Metformin may not be discontinued for minor procedures unless there is a clear contraindication like renal, cardiac or hepatic impairment or upcoming use of contrast is indicated. Metformin of course can be restarted. If you had stopped it, once you reconfirm the renal status after 48 hours of the procedure, you can restart metformin. Patients with long duration of diabetes and those not, and those who are receiving more than 2 oral drugs are likely to deteriorate. So earlier the ectomos patient admitted to the hospital has a procedure, major surgery after 48 hours, you stop all the oral drugs. A word of caution there, if there is no contraindication, you might not rush into stopping the oral drugs. Typically patients with diabetes with longer duration who've been on medications 2 or 3 oral drugs, if you stop them and the procedure is only after 48 to 72 hours, just the day before surgery you will end up realizing that the sugars have shot up to 250, 300 because the oral drugs are still working for initial 24 to 48 hours after stopping. So you could not give much insulin, but just the day before the surgery you realize that the effect of the oral drugs has gone off and the sugars have shot up to 250, 300 and then you're trying to do a catch-up act. The surgeon, the anesthetist, all are worried as to what's gone wrong. So do not always stop the oral drugs immediately. You could probably do that just the day before surgery. Insulin regimens for hyperglycemia in the post-op period, depending on the different situations, you could use different regimes. You're looking at, say, tube feeding. So I'll just focus on one. What you could do is low-dose basal insulin with short-acting insulin every 6 hours. Now, these are patients where you know that they are going to be on tube feeding for some amount of time in the hospital. They need not be kept on intravenous insulin. You could shift to subcute and use any of these regimes to achieve good control and yet make the patient comfortable. That's again a busy slide for perioperative adjustment of insulin. Again, which this, as I said, is all published data. It just tells us when we're looking at what you do. So, recommendation for perioperative adjustment of insulin for a short starvation period, no more than 1 missed meal is similar to the example I showed earlier, say a morning procedure. So, once they depending on what the patient is on, if the patient has been on basal insulin and the previous evening, no dose change. If patient is on basal insulin in the morning, you need not change the dose, you can give the dose after the procedure. If the patient was on twice daily premix, again no dose change, you will not give insulin in the morning, but post-procedure when the patient has breakfast, you will give the regular dose. So similarly, in these recommendations, you put down depending on every clinical situation that you face in the hospital and then try to be more practical about that solution. What about oral drugs? Somebody is on acarbose. On the day prior to admission, you will take as normal. In the morning of the surgery, you will be omitting the dose if the patient is nil by mouth. If afternoon, the surgery is in the afternoon, but the patient is being given breakfast in the morning, you could still go ahead and give the oral tablet in the morning. Similarly, if you say for sulfonylureas, the previous day, take as normal. In the day of the surgery, there's morning surgery. For those who are on the morning, they are on only, say, glimepiride in the morning in AM dose, you will omit the morning dose. For those who are taking morning and evening, you will just omit the morning dose, but by evening you will resume the sulfonylurea again there. So, to summarize my talk, a systematic approach in management of diabetic patients has been associated with better outcome for patients and reduce the disease burden on healthcare system. Hyperglycemia in the hospital is again any blood sugar fasting more than hyperglycemia in the hospital is the same parameters of fasting more than 126 pp, more than 200, but any sugars more than 140 is identified as hyperglycemia. The target in the ICU is 140 to 180. In the non-ICU, it's going to be 80 to 120 in the fasting. Pre-meals is less than 140 and post-meal is less than 180. Thank you so much for your patient hearing. I would like to say this is the reference, this is the group that worked on it, and this has been published in International Journal of Diabetes in Developing Countries. That's where the other slides are not referenced because it's all from here. And Inspro is the app that everybody can download for ease of use. Thank you so much.